right. All right. Well, welcome everybody. Get out of here. The crowd, quiet down. It's too loud in here. So I'm Christian Rose, a clinical informaticist and researcher at Stanford University, along with my co-presenters, Ashley Foster.
Hello, everyone. I'm Pete's Emergency Medicine and Emergency Medicine faculty at Massachusetts General Hospital.
And I'm Nick Ashenberg. I work at Stanford. I'm an emergency medicine physician there as well.
Yeah, I don't know if you guys are familiar with that place. Yeah, Sanford ER, which I keep getting in various emails. Our disclosures are that this project is supported by funding from the Ethics Society and Technology Hub at Stanford University. And then our objectives for today are first to go over a little bit of what is precision medicine, talk about precision medicine now as it entails to other specialties, and then focusing in on precision medicine in emergency medicine, and then going over an ethical framework that we've developed for sort of understanding the concerns and different elements of precision medicine in EM by providers. And then lastly, we kind of wanted your help. We want you guys to have like your phones out if you can. This way you could give us feedback and think abstractly about your concerns for ethical concerns and considerations for precision medicine in EM. So setting the scene, just wanted to give you a little bit of a like case study to think about what precision medicine might look like. So maybe you have a patient who's a young woman who comes in with chest pain and cough and maybe hemoptysis, and you're clearly worried about a pulmonary embolism. So you go to MD Calc and you put the person through all the PERC criteria, determine whether or not you're super concerned about a PE or what you're going to do from there. But you're also thinking like, maybe this person has a von Willebrand factor deficiency or some other issue that actually might put them at risk for a hypercoagulable state. Is there any like opportunity you have to understand whether they have a genetic mutation or something that might affect the likelihood that they have a PE? It's possible. They could have antiphospholipid syndrome too or anything like that, and that would put someone at risk and is not currently covered in things like PERC. And lo and behold, they have a PE. You're like, oh, okay, now I want to like give you a blood thinner. I want to put you on anticoagulation. You have a small segmental PE. What kind of therapies are available to me? This is called pharmacogenetics and is one of the more like obvious versions of precision medicine from the ER side or medical side, which is avoiding medicines that do or do not work very well in certain patient subpopulations. But we wanted to know a little bit about what precision medicine meant to you. You don't have to use the poll everywhere, which we can't use because there's no internet anyway. But maybe audience members, what do you think of when you hear precision medicine? And I know none of you guys work at an institution that this is like a heavy push for. But like, what might you think, Dr. Rice?
Well, I'm getting the same result from the same test is what precision means to me.
I like that.
Yeah, so things that are reproducible.
Okay.
And it's going to give you consistent results.
Cool. Anyone else? Dr. Brown, maybe?
I kind of think it the same way. The one thing I add is how do you improve outcomes by creating the best tailored care that you can and use as much data as you can to help make that happen. That's how I view it.
All right. Anything else?
I don't have anything else to add.
All right.
But I think I also agree with like just kind of more of an outcomes-driven model.
Yeah. Cool. All right. I'll hand it over to Ashley to give her thoughts on what this means.
So as we're all hearing, based on everyone's thoughts, precision medicine can mean different things to different people. And it's actually a very rapidly changing and dynamic area of medicine. And just to give a little perspective in terms of when it's become a bit more popular, in 2015, Barack Obama launched an initiative actually called the Precision Medicine Initiative. And the phrase to enable a new era of medicine through research, technology, and policies that empower patients, researchers, and providers to work together towards development of individualized care. Sounds a little vague though, unclear what that may mean. And this initiative did bring a lot of attention towards precision medicine. But precision medicine was actually here before 2015, and it was initially called personalized medicine, and that is now not the phrase that's used to describe precision medicine. And it was in 2011 that this switch occurred, and the National Research Council gave a strong rationale because shouldn't all medicine be personalized? And the focus of precision medicine is really to explore how treatment or prevention approaches can be developed based on a combination of genetic, environmental, and social factors, which could be targeted to the individual, but also could be targeted to populations. And highly personalized information may or may not lead to actual improved health outcomes. And moreover, precision medicine approaches may lead to non-personalized interventions. And so there have been many words to describe this idea of precision medicine, and it's a moving target. The existing definition that is in the Precision Medicine Initiative, which is the report that was created after Obama's Precision Medicine Initiative, is an approach to disease treatment and prevention that seeks to maximize effectiveness by taking into account individual variability in genes, environment, and lifestyle. And so how can we think about precision medicine? And I think the most common ways that I had thought about precision medicine beforehand was really in fields not emergency medicine. So the classic example is in oncology, and really where it's been used most so far, and the example being with HER2, thinking about how discovering the epidermal growth factor receptor led to treatments tailored to that receptor, trastuzumab, which has made a significant difference for a specific patient population. Near and dear to my heart, pediatric epilepsy, precision medicine has actually been used in this area as well, thinking about how can we identify specific genetic abnormalities that may lead to severe epilepsies and epilepsy syndromes, and then are there ways that we can use that information to tailor specific anti-epileptic medications? But we don't work in those fields. We work in the emergency department, and thinking about how precision medicine can be brought into emergency medicine, there are a lot of exciting thoughts, but also maybe a lot of challenges to thinking about how this would be applicable, and thinking about how we can integrate the idea of the right patient, the right place, the right time, anyone, anywhere, anytime, and where does that come together? And so there have been published tables and thoughts about all of the opportunities that precision medicine portends, and this is just an example of several, thinking about improved disease classification, non-invasive testing, the idea of shifting to prevention instead of treatment, and is there a role for that in the emergency department? And then thinking about patient-centered medicine and how this can help deliver better patient-centered care. But there's always the other side. And this is something that the New York Times in 2018 called out about precision medicine, and the fact that really what had been previously published were the sunny and rosy outlooks of precision medicine, and that there's not enough discussion about when precision medicine doesn't work. And this article highlights for patients with cancer the fact that precision medicine fails more often than it succeeds, and only about 10% of patients who get targeted therapy actually really benefit from it. And that's a significant number that should be reported and shared more often. And is the public being misled by precision medicine? Not to mention the potential cost that it holds for patients.
So has anybody seen the movie Gattaca or Minority Report? Okay. I feel like there's elements of this that are brought up in a book called Weapons of Math Destruction, which is really a wonderful book everyone should pick up. It's a pretty quick read about the sort of dangers of using data for specific interventions. It goes over some of the flaws of things like stop and frisk, or the fact that once you start measuring a specific cohort, you might actually start seeing differences that are more related to the environment that those people are existing in than particularly any causative nature of what you're measuring in the first place. And so just a reminder that, like, for Gattaca, it was that, like, you wouldn't be able to go to space if you didn't have the exact, like, right genome, and then everything ensued from there. Or if you start making predictions for people, a la Minority Report, are they then beholden to, like, sort of this track that you've just put them on, and all the assumptions therein? It starts getting a little gray, but those are some of the concerns that have been brought up in pop culture.
And so these are challenges that have been previously published in a systematic review that was performed in 2017. And as you can see, a lot of these, you can imagine how they're applicable to our practice setting. And I want to focus your attention to the fact that this one little box probably requires its own special place because it's a big issue in terms of ethical, legal, social, and consent issues that come with precision medicine. There's actually a paucity of literature that really explores how we as a field, not just emergency medicine, but medicine, are really going to be addressing these significant challenges that may come with integrating precision medicine into practice. There have been proposed frameworks and ways to think about the ethical considerations around precision medicine, and this is an example published by Solari et al. That talks about some of the pros and cons that they could imagine and that have been published with precision medicine. Some of these feel like they can be used or are applicable to emergency medicine, but some not so much. And so this led us to our project, which Christian will tell you a little bit more about.
Sure. So thankfully no one in the audience was actually in the session, but we basically, based on the fact that there was no ethical framework or way to address these issues, they were just sort of brought up as very piecemeal, like, oh, we have a problem with this one specific element of implementation of precision medicine or another one. We sought out to basically hold a session to advance the understanding of the ethical challenges that patients and providers alike may face as we start moving towards effective precision medicine. So what we did was a process called a nominal group technique study, where you get a group of people together in a room that in theory are experts on this. It's a little bit different than, say, a Delphi study, but you ask people across a range of like age groups, demographics within an area that you're trying to better understand, and you ask them just to brainstorm and go around the room in a very non-judgmental fashion. And this is how to do one, according to the CDC. Actually, it gives a great how to run a nominal group session. But we had a group of 11 different emergency providers across training levels in different subspecialties of emergency medicine, who basically would sit for 15 minutes, come up with everything that they would be worried about, and then we would organize all of those concerns as a group. And so basically what we wound up coming up with after an hour of around the table discussion were 93 general concerns, which were across 60 unique topics. So some of them were repeated, some of them got at the exact same thing, just worded slightly differently. And we found that when the whole group sat down and mapped these out to where they thought they were in terms of importance or relation to other concerns, we wound up with 9 concept areas across 3 different dimensions. So one element was time. So does this have to do with data that's already been acquired or at the point of care? Or now that someone's been treated by something, what happens afterwards? Now they're becoming a data element, and that can affect other people down the line. And that was sort of the timeliness of all the concerns. And that was across considerations like privacy, values, and justice. Privacy being obviously concerns of where the data is coming from, stored. Values, which are who are we accounting for? What concerns are they? They're the patient? Is it the health system? And then justice has to do with, well, these things happen and have obviously negative effects, but what's entailed? So some of the examples, we'll just sort of blow through these, but to give you examples of the concerns that came up, we're going to go from across the privacy realm through time. On the acquisition side for privacy, how are we assuring that data stays private? What happens to data from minors or at-risk populations were some of the concerns that were raised. In terms of actualizing that data, how do we know that what features are being given choices and what those are based on? So if someone comes into the ED and we have the PE example, are we making decisions based on the patient-centered outcomes or just our assumption that we know what the patient wants? Also, what do we do with incidental findings? The after effects on the privacy element are how and why and for what purpose is someone's information then being shared after you have intervened upon them? And who determines whose data is cohorted with whom? Are there different ways in which my data is just going to be with, like, say, Stanford people versus will it go into national databases, or what happens to it from there? Do we have a choice? On the values axis, we then had, in terms of data acquisition, who decides what features are measured in the first place? Obviously, this goes to that book, Weapons of Mass Destruction. What are we deciding? Is it recidivism? Are we deciding likelihood of a patient to come back for a return visit? Are those things that we should even be considering in the first place? At the time of actualization, are we able to, in any meaningful way, listen to someone and incorporate their decisions at the point of care? And then how might those choices affect people down the line? So if Ashley would like different medications or opportunities than I would or Nick might, does that then fundamentally mean every data point that looks like Ashley down the line is beholden to her choices? Finally, on the justice axis, we definitely have an issue of biased and incomplete data sets. There's tons of references and historical information from studies that were done during Nazi Germany. There's things through the Tuskegee experiment. What happens to that data, and how do we actually determine whether or not we should be using it in the first place, or whether it's being used for the purposes that are right for the patient at hand? For actualization, we want to avoid this digital or genetic determinism. Someone does have a choice and they should be able to make those decisions themselves. That's the sort of minority report kind of concern. And then lastly, how might the effects from one subpopulation affect other people like them? And what are the ways in which this can be used or weaponized against certain populations? All right.
So as Christian just mentioned, we organized all these responses into these 9 little squares. But in looking at them again, we noticed there were some recurring issues over the course of the exercise, and we're going to run through those. And if you guys have things to add to or questions about it, we can talk about it, or there's going to be a discussion afterward, hopefully. And
Please speak up and raise your question.
yeah, same with Christian and Ashley. If you guys have things to add, please do. How are you advancing the slide? Just the arrow?
Yeah.
So the first central theme that came up when we were talking about these 90 questions is, again, how accurate is the data was one thing, and do we trust it? Because garbage in gives you garbage out. And how are we acquiring this? Is it self-reported? Are we pulling it from the medical record? What population are we sampling? Are we oversampling a certain population? There are lots of questions about what does this data look like? And the bottom line is that flawed data in gives you flawed data out. And while acquiring the data is the first step, ultimately, precision medicine is a feedback loop. There's no steady endpoint of precision medicine where we can finally say precise medical care is provided to all patients. It's a cycle that implies ongoing efforts are ever more precise. And that said, the results of these analyses inform further assessment of patients, so the outcomes modify the inputs. So it's not so much precision medicine, but more maybe a precising medicine, as this Dr. Koenig, who wrote a paper where this feedback loop came from. And if we have the wrong inputs, it could broaden the disparity between groups and maybe take us down the wrong path. Social determinants of health was a common thing that came up. I think this picture actually does a good job depicting sort of what goes into your health, and we all know it's more than healthcare and health behaviors. Your physical environment, whether it's how close you live to the highway, plays a role as well. But certainly the socioeconomic factors, your education, your job, your income, your social support, the community you live in. And I think the big question was, or a lot of the questions that came up really spoke to how do we weigh these values of lifestyle against other concerns that are going into our calculation. And worse yet, does dividing people further into these groups or subgroups based on their lifestyle further lead to stigmatization or discrimination? Access to precision medicine is intimately tied to social determinants, but there's more to it than that. And one thing we were just sort of kicking around in this group is, what if hospitals haven't implemented it? Like, you're more likely to get precision medicine if you live in Palo Alto than you probably are in rural Maine, for example. And that brings up the question of, for those who have been historically excluded from care, will that continue to be the case for them? Will precision medicine simply promote, or a concern is, will precision medicine simply promote the haves just keep having and the have-nots just keep not having? Preserving the holistic human was central to our discussion. The idea being that precision medicine may reduce patients to just a few factors. We become data points rather than viewing you as a whole person. Does what makes you you matter anymore? We box people into these discrete digital bytes and use medicalized terms, but do your values play a role at all? And how would we even measure those? And then Christian just mentioned this, but choice was a major theme. Choice for lots of different entities involved. Does the patient get a choice of their treatment? Can they opt out of the precision medicine plan? Is a non-precision medicine plan even available to them? Do we want it to be? Maybe the right treatment for patient A is not the right treatment for human A. Like, the analysis says the patient should be admitted and they don't want to be admitted. Same with providers, like the choice in what treatment we do give people, that's a question as well. And all of these things, as I mentioned, it's a feedback loop, so it will impact things downstream and upstream. In the emergency medicine department, obviously timing is important, and how will this information be provided to us? We're not going to be sending genetic studies on people out of the ER, so we're going to be relying on information that's previously been gathered. And often we see patients that we can't even identify, let alone we're calling them omega because they're an unknown entity when they show up. We're not going to know the variables to this analysis. Can't talk about medicine without talking about payment. Who's paying for this? Who's paying for the research, the treatments? What if you don't have the ability to pay? Are we only going to research lucrative diseases or conditions? Is there corporate influence? And then just a couple more. Some legal matters came up in this group. Who has access to this data? What do we do with minors' data if parents consent for their children and the children don't want information that might come from the result of this? How do we cover that? Education and communication, like how do we communicate precision medicine to the public, like those articles that we saw in lay publications. How do we educate ourselves? How do we stay current? How do we train our residents in precision medicine? And then lastly, what's the scale of this? Whose interests are in mind? Is this purely focused on the patient and what's best for the patient, or is it what's best for the hospital, or what's best for society in general, and do these even align? So lots of questions, and we thought they weren't really amenable to ranking, but I don't know, this was gonna be a thought cloud if the QR code, but it's not gonna work, right?
Maybe we should try. We should try to see if with your,
Yeah.
so just to, if you guys can take a picture, and that way it also can make it anonymous, which we thought would be helpful for the exercise. And so if you could rank these issues that we've introduced to you all in terms of what we should be prioritizing and thinking about and addressing if we are only able to do one at a time or a few at a time, what do you all think is the most important as it pertains to emergency medicine? We'll give you a couple minutes.
And it's gonna show up on your,
In theory, or recycle it. Let's see.
Like,
We got nothing.
A couple minutes.
But
we do it?
Give them a couple minutes, yeah.
Or we could just talk about it too.
Yeah.
I don't know if, I
We'll
feel like.
give it a couple minutes and then we'll talk about it, yeah.
Okay.
I get to make an account, pullout.com.
Oh, man.
Oh, no.
Well, now they have your data. So.
It's just asking me which cookies I want to be tracked by.
Chocolate chip only. And then I think you can upvote the different things depending on what
Oh, wow.
Yep. Now it's moving on the screen here. Oh boy, seeing the whole person got one vote.
Yeah,
Nice.
after I submitted a different answer.
Yeah.
And you can be changing your answer
Yes.
too, based on other people's, so.
Yeah, like the presenting computer doesn't have the internet, but it looks like seeing the whole. So right now the top one.
Sorry. I got like, took me to the app.
Well, at least the QR codes are working. It's good to know that.
I think they're hard to rank. I mean, the whole person makes a lot of sense, but it all
Yeah.
begins with sort of the data you put in, or how are we doing these
Yeah.
calculations, or whatever we're calling precision medicine.
Yeah, basically what wound up coming up in our session was that people felt very uncomfortable ranking because they felt like each of these would then, it would be sort of disingenuous to choose that you think that identity has a higher priority right now or privacy over other things. And so what ultimately we wound up settling on as a group is a sort of framework where you can address or try to make sure that whatever is coming up is within this like framework of high concern elements, which may or may not ultimately be true as a sort of first step for nominal group sessions. That's what people came up with. I don't know what you guys think about that, but does something like jump out as like way more important to you than
What do the
anything
results
else?
say?
The results say garbage in, garbage out. Seeing the whole person and social determinants were even, and followed by 2 more garbage in, garbage out. So I'm guessing that actually has 4 votes.
That's surprising.
The amount of error introduced by our sample size.
Yeah.
Considering.
Yeah,
And I was just wanting to see if I could trust the thumbs up on
yeah,
that.
yeah.
And I-
Brian's really throwing off the research. Yeah.
I just think there's so much bad data in our system.
Yeah. Can you elaborate on that more? Yeah, what's bad about it?
Well,
What do you feel about
I
it?
mean, the human error of what people put into the system
Mhm.
is like, I don't even know how you screen for that. And I'll just give you an example, like one of our residents just put in like a misdiagnosis,
Yeah.
and then it did placed a referral associated with that diagnosis, and so I couldn't even delete the diagnosis. And this patient had a completely wrong diagnosis,
Yeah.
and I couldn't delete it. And so now, I mean, it wasn't like a huge deal, but it was a
Yeah.
incorrect diagnosis.
Yeah, if that had been something else, that could have been a protected health information
Yeah,
concern for
like
them, or could
HIV,
flag their,
hepatitis,
exactly,
whatever
could
it
flag
was.
their insurer or something too.
Yeah, and you look through like all the ICD-10 codes and all this, like these patients like problem lists, and they're just like, it seems like it's garbage.
Yeah.
Like it's just like
Mhm.
pages and pages of things, because somebody put like, whatever, I mean,
Yeah.
whoever inputted that data.
So one of the key concerns what I'm hearing is that there's a lot of noise, and the signal to noise ratio is off, at least right now. And I think most of the people in the room probably agree with that because we're still in the nascent phase of involving this. But there is also efforts right now to try to remove like spurious information and to try
Yeah.
to like keep it more precising of like this thing has been on here for a long time. Maybe we need to have people go through and remove stuff.
Yeah,
as
and
well.
once it gets entered, it just gets like
Yeah.
graduated down.
Yeah.
It's like the perfect example is like if anyone works at the VA, like everyone just cuts and pastes your notes,
Yeah,
and so like the same diagnoses like follow you, and
forever.
like, yeah, I mean, I think that the data input is important.
It's tough too, 'cause some of those like data issues are because of the perverse incentives behind all of this, right? I mean, we're using fundamentally billing software as we get right?
Yeah.
It's designed to produce as much
Yeah.
volume of stuff as possible in order to upcharge a system, and then
he's like, actually, I feel like I heard mostly, and that was, there's a trust element too. Like, do I trust the system to make it possible? Which didn't come up in in a lot of our discussions, but I do think is something that comes up a lot in the AI world too. Is how confident am I that I am able to like use this tool effectively, or that this will work for the outcome that I care about? I don't know either. I've become a bit of an analyst as well.
I think there's this, like, oh, should I trust this? Like, the preconceived notion is that we're starting from a place of trust. Like, we already have an inequitable, horrible, greedy system that's collapsing on itself. Like, the idea that we can build something that wouldn't, I don't know. I think it asks too much of, like, the technical question to also solve the ethical questions that we're currently in. Like, I don't think you can expect us to become different people and have different systems just because it's a new tool.
And like to the like social determinants part of it, we have two different systems in our healthcare, right? One is like incentivized to provide service, and one is incentivized to not provide service. And so, how do you like balance those two together, and how do you get people who don't have access to care a system that's inherently designed to prevent them from getting care?
I think importantly, it also underpins the whole idea of garbage in, garbage out, right? Like, it is not the patients that have access to the best care that are going to see specialists that have diagnoses that aren't true,
Yeah.
or that you don't have a complete EMR for, or that get discharged early and don't understand their meds. Like,
Such a great point, and definitely came up in the discussion. There were several comments about, like, why should we be focusing on this at all when we can't provide access to care of our patients right now? Like, why should we be adding another way to limit access, so to speak?
There's different incentives too, right? Like, as physicians, we want to like provide care. As like private equity in medicine, oh, maybe this is great because we can like cut costs here and there, but let's just forget about these other people who were not invested in that healthcare system.
Or give us the map that says that we can cut costs for them. I think that's an interesting concern too, is that, thank you, now I have the evidence that says you don't get a kidney, you do. And that wasn't me saying that. It wasn't like my ability to get you onto the list. It was that the computer said. The computer says no. That's a good little written bit.
Yeah, we see it now with all those like utilization reviews, you know, like people just like, oh, here's this evidence to deny whatever treatment you have.
And I think the cost element that I thought was really interesting, and I didn't quite think about, is thinking about the inefficient ways that we practice medicine, speaking to what you're getting to, that there's this idea or promise that precision medicine could actually minimize that, could decrease that. If you're providing treatments that are ineffective or harmful, inadvertently harmful to the patient, they have an adverse reaction, there's a medication interaction that wasn't known, could precision medicine actually really help to reduce that harm and burden? But the flip side is, what is the cost to get us there? And I think that's really what stood out more than the potential cost promise that it holds.
Compromise seems to be coming up from both you guys too a lot, which I think is an interesting one too. Or like, where do we balance? Which was one of the concepts for us was scale. Like, a lot of people were like, well, the individual has desires, hopes, and dreams, but whenever we practice the Kaiser model versus the fee for service, those have very different incentives, which are not necessarily aligned around the individual either. So precision medicine can be taken from a population level to affect an individual, and vice versa. But how do we draw that line, and how do you navigate it? I don't know.
It's talking about at implementation, both at the systems level, right? Like, I've got this thing that's going to reduce costs, right? To reduce inputs into this voracious system that has an endless appetite for money. Does anyone actually want to put that in? Right? And we're going to, Stanford University, to take an example, because a couple of us work there, that we will create fewer bills, right? Is that at all something that they want? Like, no, right? Like, why But like, it's saying that like, you can't do this study that you want to do, and we're used to being able to do everything that we want to do, and that's our right, and we pretend it's the patient's best interest or our interest, or, and I think there's some things that we don't want to do that we love to have. The computer tells me I can't give you the CT that I already know that I don't want to do. Well, what
Yeah.
happens when it tells me that's the thing that I do want to do,
Yeah.
right? And I just don't know that we would, like, would we ever use a tool that didn't let us do exactly what it is that we want to do? Like, if we're going to, how different does the training to make that doctor have to be?
Yeah.
Because I don't know at this point, as a, mid-career grumpy man, like, if they gave me a, like, you can't send an age until you be 27, this is not, but it is, I know, I'm so smart,
Yeah.
right?
I think, and that gets into parts of the reductionist, like you're then trying to say like, yeah, don't think holistically. Try to think in terms of like, yeah, the task at hand, and it takes away some of the like part of the joy of practicing, and also leaves people with choices that they might not have be informed or have the education to make an informed decision about. Because we also know numeracy and the way people interpret numbers is highly different too.
Well, it takes away from everything you learn in medical school.
Right.
Like
Yeah.
all of your like training from the beginning, it was like touchy-feely.
Yeah, that's the gestalt, and
Yeah.
listen.
Yeah.
And that comes up a lot in terms of not just for the patient, but for the provider. Is this a practice of medicine that I would even want to do? Does it change it so much that the patient-provider experience is not one that I find valuable anymore? And that's something that hasn't really been explored in terms of thinking about the integration of something novel like this. Does it absolutely change us as providers, how we experience emergency medicine?
Yeah.
What do you like giving people choices in their care based on data is made for the healthcare literate, educated
Yeah.
person, right? I mean, like you pull up PCARN and try to talk a parent out of like not getting a head CT, and then you do it for someone who's really poor healthcare literacy. It's like you're trying to not give me care that I think I need. Like it just doesn't.
Yeah.
It's not a good fit, I think, for everybody.
I had a biophysicist patient a few weeks ago that was like, yeah, you don't need to explain the answer to me, I got it.
Yeah.
Like, I don't want any of these tests. I was like, all right, cool.
My pretest probability.
I was like, this is great. I'm gonna walk out.
And I feel like, precision medicine, like the idea, sorry, individually taught, I just can't stand using the word precision because that's not actually what anyone's talking about, but like,
What do you think we're talking about? I'm having a hard time. I think that's what comes up too. And the name change, I think, is actually important because I used to get really annoyed by personalized medicine. So I was like, you've actually impersonalized me. You've turned me into a comparison to everyone else and not listened to Dr. Rice's story when he's coming in and why he's here and what his concerns are. And sometimes concerns are comfort or like letting someone know what the next steps will be, not doing the next steps too. At least that comes up in my research a lot. Is like just what next, which isn't the same.
yeah, I mean, I think a lot of this is about accuracy, right? Not about like precision. I mean, there's been nothing about repeated measures and any of this stuff, and just that. I think having that as like a basis for this is a little bit weird. But I mean, it's this idea of these, tailoring it in some way to be a better guess as to what's going to be the effective next step, right?
Yeah.
Like that's what question to ask next to differentiate whether it's what test to investigate, whether it's a treatment modality. And the farther
genetics that people will get an answer in the 90s. The whole, clearly, your slide is like, it's a fraction. Your genetics as opposed to your environment and epigenetics, even if you wanted to get into these, are a fraction. And I'm hearing one of the things from you discussing too, which I'm kind of passionate about, is the unknown unknowns, which is just because we've shown light on something that we have decided is like an important risk factor or whatever right now, doesn't mean you actually have any clue in the comprehensive space of what could be the bigger next thing. And this reduction, like, okay, then run this for everyone, actually doesn't help you gain new knowledge. What you want people to do is not be hindered or weighted down by just what's available at the time. And then there's another concept that was coming up there too that I like is pathways versus just in and out. I think when people think of precision medicine, I wonder what you guys feel on this, they think of gating, like a computer, like you put this in and here's the output, but realistically medicine, there's a paper by one of my mentors, it's called like diagnostic wayfinding. And it's really this process of what's important when, and I think that timing is not met well in these models, and as from the ED side, I think really interesting. You start with concerns and you move towards some, and that, in nowhere in that potential space might be something that's gonna kill you. So I can actually defer that choice till a little later as other things become clear or options become available. But there's this also concept to me when people think of precision medicine, that is, you come in, I can get everything I need and I can push out a result, but I don't know that that's actually A, necessary, or B, complete.
When I think of like dream, so like building off that, when I think of like my dream tools in this space, it's something that is like monitoring my note as I put it in, or somehow happens in real time. That like it's like you needed to ask this because there's this whole other like investigational space that we can't link to that has possible tail. That like that thing could mean something if we had this information, but like you didn't think to ask to open that up. Like those are the sorts of things. Like how can I ask more of the correct open-ended questions if there's, you know, like find somewhere where there is no important information about their travel history. Like them coming back from Sri Lanka yesterday doesn't actually affect what's going to happen. I shouldn't be encouraged to ask about Sri Lanka, but maybe I should be asking about these other things.
What are we missing? Yeah.
Yeah.
I think that's
And I just think that that's like how to open up what we don't know isn't usually how we think about using these tools.
I think that is, I had made I feel like it was with you on shift. I made a model that was like, there's a precision PM tends to be like potential space of all the things, a triangle. You're like, oh, you come in, you have all these things, we're gonna narrow down to like the end point. And my model, we called it like the iceberg, is in the end, you probably start with a potential space. You should broaden first. So you go outward, and then you narrow some, but not all the way, and then that someone else can potentially do at a later time. And so one of our jobs, this phase, is to actually, when someone comes in, is like, my foot hurts, and we're not like, did you roll your ankle? You're also like, do you have gangrene? Are you numb in your foot? Did something else? Like, there are all these other questions of like arterial injury that you should broaden before you begin to narrow. And so I do worry about as well that phase of like, the idea that you're just going to take everything and go, you actually want to open and shed light on some areas that you haven't asked about.
I had a very similar diagramming conversation with an intern like 2 days ago, where you know, like you have this universe of diagnostic possibilities and someone says foot pain, and 90% of those collapse within the first, even though you don't realize it, within the first 15 seconds in the room, you're like, oh, it wasn't cut off, right? And so all these, how did your leg get cut off questions, and like that collapse is so interesting, but like probably I'm collapsing on some things that I shouldn't, and that, you know, I need some more, and I think a lot of what we do is getting people down to like a minimum number of buckets, right? Like how many things did your belly pain be going home? Like I took care of things, but like, you know, like there's still this couple, and having that be an okay output for a system is like so uniquely EM, and I think maybe if I was in like a derm precision medicine lecture, there's maybe things that are so uniquely true to them that I can't even comprehend like what their interaction with patients and precision medicine.
Thank you so much for coming and for participating and having such a wonderful and engaging conversation. We really appreciate it.